Welcome back to the Washington University Emergency Medicine Journal Club podcast, September 2015. This month we did a pediatric topic, so a topic for the kiddos. So I'm joined by a couple of our pediatric emergency medicine colleagues, joined by Dr. Indy Trehan, who has been on the show a couple of times before, and you know him well. Indy, thanks for being here.
Thanks for having me back, Brian.
We're also joined by Dr. Katie Leonard, one of the pediatric emergency medicine fellows, who led the conversation this month. Katie, thanks for being here.
No problem.
All right, Katie, tell us about this topic, what we talked about, and why you chose it.
All right. The topic that we chose for this month was discussing alternatives to rectal diazepam in the treatment of patients presenting to the emergency room with seizures. So when kids come into the ER seizing, we generally try to treat them with benzodiazepines as quickly as possible once the seizure's been going on for 5 minutes. Ideally, we're able to get IV access quickly and give IV lorazepam or diazepam, but in the real world, getting IV access can be hard in a seizing child. The kids that come in with seizures are often either chubby babies, chronically ill kids that are spastic and have contractures. So we have to have alternative methods. At our institution, our guidelines call for our first-line alternative method of giving benzodiazepines as rectal diazepam. That, too, has its own real-world challenges in administration. Getting the pants off a larger child or one of those chronically ill children can be challenging. Effectively protecting and supporting the airway while trying to maneuver the patient into a position where you can access the rectum can be hard. And then ensuring that it was delivered correctly with a very limited view in most cases are some of the challenges that we face giving it in a timely manner. In addition, the dosing recommendations for Diastat can be challenging to remember in acute situations. The dosing is based on age and weight, and often you have to look at the chart to give the appropriate dose. There have been a number of studies comparing alternate methods of administration of benzodiazepines by the buccal route, which can be challenging in kids who are seizing in clenched teeth, IM, and then intranasally.
Doesn't seem like putting your fingers into the mouth of a seizing child is a great idea.
Yeah, agreed. So the apparent ease, it makes sense that intranasal might be the best and easiest option out of all of those. So we decided to look at the available literature that addresses using intranasal midazolam to control seizures. We selected 3 studies that compared intranasal midazolam to rectal diazepam and 1 study that compared intranasal midazolam to IV diazepam.
All right, Katie, well, tell us about the first article that we looked at.
So the first article was called The Effects of Intranasal Midazolam and Rectal Diazepam on Acute Convulsions in Children, a prospective randomized study. It was by Fiskin as the primary author and his colleagues from Turkey. It was published in the Journal of Child Neurology in February 2002. This was a prospective, somewhat randomized study. We say somewhat because the quote-unquote randomization was to treat patients presenting on odd days with diazepam and patients presenting on even days with midazolam, which isn't true randomization. But so in a period of a little over a year, a total of 45 patients between the ages of 1 month and 13 years were enrolled in the study. Patients were eligible for enrollment if they'd been seizing for at least 5 minutes, regardless of the type or etiology of the seizures. There are no significant differences in age, gender, or presence of fever between the groups. The paper reported no significant differences in the type of seizure, although 30% compared to 13% of patients in the midazolam had only simple focal seizures, which may be clinically significant, even though they didn't say it was statistically significant. And they found that 87% of the patients in the midazolam group had cessation of seizures within 10 minutes after the drug was given, compared to only 60% in the diazepam group. So that correlated to a risk reduction of about 27%. When the time to seizure cessation was broken down into increments, the seizures were overall terminated more quickly in the midazolam group, and more patients in the diazepam group needed a second drug to stop their seizures. So overall, this study concluded that based on the duration of the seizure following the administration of a drug, that intranasal midazolam was more effective than rectal diazepam.
Yeah, this study had several methodological flaws. The first thing that Katie mentioned was the quote-unquote randomization by day of the week. There was no sample size analysis. There was no real clear hypothesis or primary outcome specified. But my takeaway from this is that it at least shows that there's sort of a non-inferiority to the nasal midazolam. It sort of provides evidence that there's some plausibility to that should be studied in other studies that we'll talk about. Not enough to change my practice necessarily from one study that isn't well designed or perfectly presented, but at least enough to provide support to this idea.
Yeah, and the other problem, they didn't really provide a lot of demographic information, medical comorbidities, underlying cause for seizures. I mean, Turkey isn't exactly a third world country, but at the same time, there are certainly some infectious processes that go on that we may not have here in the United States.
And then the other thing that this study kind of left out was other patient-centered outcomes. So yes, it looked at how well the drugs worked at controlling the seizures, but didn't mention any of the other things that would be important in deciding which one to use, like respiratory depression, duration of sedation, how long they had to be in the ER or get admitted to the hospital. So those are all important factors that play in your decision about what to treat patients with that they did not comment on.
Okay, why don't we move on to the second study?
All right, the second study that we talked about was called Pre-Hospital Intranasal Midazolam for the Treatment of Pediatric Seizures. This was published in Pediatric Emergency Care in March 2007. Primary author was Holste, and it came out of the University of Utah in Salt Lake City. So this was a before and after study that was conducted within the EMS system in Salt Lake City. A new EMS protocol was introduced that replaced giving rectal diazepam as the first-line therapy for patients with seizures by EMS providers with giving intranasal midazolam. And the study then compared the characteristics of patients who were treated with intranasal midazolam after the new protocol was implemented with historical controls who had received rectal diazepam. The patients that were included in the study were less than 18 years old. They had a seizure in the presence of an EMS provider. They received the rectal diazepam or intranasal midazolam in the pre-hospital setting and were brought to the ED by EMS. So with those inclusion criteria, they ended up with 57 patients. 39 of those patients received intranasal midazolam after the new protocol was implemented, and 18 received rectal diazepam. The patients were similar with respect to age, sex, etiology of the seizure, and history of prior seizure or use of anticonvulsants. The primary outcome that this study looked at was the presence of ongoing seizure activity in the ED, and 38% of patients who received intranasal midazolam still had seizure activity on presentation to the ED, compared to 72% of patients who got rectal diastat. When you do the math, that gives you an odds ratio of 4.16. So some of the other numbers that came out of this study that were interesting were that total seizure time was longer in the diazepam group at 45 minutes compared to 25 minutes in the midazolam group. And the EMS witness seizure time was also longer in the diazepam group at 30 minutes compared to 11 minutes in the midazolam group. And both of those were statistically significant differences. Patients in the diazepam group were also more likely to require bag mask ventilation, intubation, and both hospital and ICU admission than those in the midazolam group. Some of those outcomes are likely related to the fact that the seizure activity was of much longer duration in the diazepam group. And then finally, the total hospital charges were significantly less in the midazolam group, on the order of about $5,000.
So pretty much, intranasal midazolam kicked diazepam's butt in this study. Is that what we're saying?
In this study, but we talked about some of the problems with the before and after model.
Yeah, the before and after model is really not anywhere near a gold standard in evidence-based medicine.
Yeah, Andy, I think you pointed out at Journal Club that the big problem with the before and after study is anytime you implement a change, like a change from diazepam to intranasal midazolam, it's usually not just one thing that changes. There's usually a whole big protocol change that goes along with it and a lot of other things that change as well. And it's hard to know whether it was just a change in the drug that resulted in the improved outcomes or a change in the entire system of how they cared for pediatric seizure patients.
Absolutely true. Yeah, there's changes that usually come as a package, and people like to attribute improvements or decreased performance to one key factor. But when you're right, it's a whole big change. But I think we really have to give these guys credit for doing this study at all and for collecting this data and going after what is really a quality improvement sort of study where the EMS system got together and had the guts to just make a big change, looking at the available evidence that was there at the time and keeping track of whether this quality improvement change really showed some improvement and sort of followed a cycle of, well, let's make a change, let's analyze, let's see if we need to make more changes, and sort of go in an iterative loop like that. And in emergency medicine, this is something we almost have to do because we often don't have the evidence available, and we often don't have a chance to randomize or consent or do the sort of traditional EBM things that clinical trials and other settings can do. When you need to make an emergency decision, provide an emergency intervention, whether it's in the ER or even more so in the field, you don't really have time to consent and provide all that information. So these guys went with something that has good biological plausibility, that was safe, and then they were rigorous enough to keep track of their outcomes. So props to them for doing that.
All right, the third article, Katie, you ready?
So the third study is called Intranasal Midazolam versus Rectal Diazepam in Acute Childhood Seizures. It was by Bhattacharya and colleagues out of New Delhi, India. It was published in Pediatric Neurology in May of 2006. So this study was conducted in both the outpatient neurology department and ED settings at their institution. It included patients between the ages of 3 months and 12 years who presented with all types of seizures. The randomization for this study occurred by shuffling an equal number of sealed envelopes containing the drug to be administered and then selecting an envelope at random each time an eligible child was enrolled.
That's Las Vegas style randomization right there.
Again, in this study, the dosing used was the same. It's 0.3 mg per kg of rectal diazepam or 0.2 mg per kg intranasal midazolam. So this study captured a total of 188 seizure episodes occurring in 46 children. Diazepam was given to treat 96 of those, and midazolam was given to treat 92 of those. There are a relatively large percentage of simple partial seizures that were treated. 49% of the seizures were simple partial and may not necessarily be the type of seizures that we would treat with a benzodiazepine in the ED. And then the underlying diagnoses related to the seizure etiology are quite a bit different than the patient populations we typically see. But overall, the baseline characteristics between the two groups were similar. And they found that intranasal midazolam was administered more rapidly than rectal diazepam, only 17 seconds faster. So it was statistically significant, but I'm not sure the clinical significance of 17 seconds. And then the duration between the drug administration and the cessation of the seizure was also shorter for the midazolam group. The seizure stopped 62 seconds faster on average in the midazolam group. So again, not a full minute, but the clinical significance wasn't really elaborated on. They commented that there were statistically significant decreases in oxygen saturation at 5, 10, and 15 minutes after giving diazepam compared to midazolam. It did not say the degree of hypoxia that patients experienced, and only one child in the diazepam group needed oxygen. So again, the clinical significance of these differences is not apparent.
So it sounds like there were a few improvements with midazolam, but they were improvements that may not be clinically significant, even though they were statistically significant. And that's actually an important point. Anytime you're looking at a study, just because they demonstrate a statistical significance between two groups doesn't mean that that significance is clinically important. If they only had to put oxygen on one diazepam patient, then probably the oxygenation differences are not that important. So in this study, about 90% of the patients had a history of birth asphyxia. They had a large number of patients with neurocysticercosis and a large number with something called degenerative brain disease that they don't really define very well. So this is probably pretty different from our patient population. I don't know how clinically important that is in terms of patient seizing in front of you want to stop seizure, but it is a somewhat different population.
Not a study with fantastic methods and not a study that's fantastically presented, but again, providing some at least indirect support to this idea of using intranasal midazolam as an alternative. Doesn't scare me away from it, at least.
All right, continuing on our journey around the world, we're going to move on to Israel now with the fourth article.
Yeah, so the fourth study, like I mentioned earlier, is a little bit different. So we've looked at two that have compared intranasal midazolam with rectal diazepam. This fourth study is a little bit different because it compares intranasal midazolam with what is arguably kind of the gold standard treatment, IV diazepam or lorazepam. They're interchangeable. But so this study was called Comparison of Intranasal Midazolam with IV Diazepam for Treating Febrile Seizures in Children, a prospective randomized study by Lahat and colleagues, and it was published in BMJ in July of 2000. So, as the title suggests, this was a randomized controlled trial performed over a 12-month enrollment period. Children between the ages of 6 months and 5 years who presented with febrile seizures lasting at least 10 minutes were eligible. Patients were excluded if they arrived to the ED with IV access already established or if they had received anticonvulsants prior to arrival. They were randomized to, again, receive 0.2 mg per kg of intranasal midazolam or 0.3 mg per kg of IV diazepam. The outcomes that were measured included successful treatment of seizure, which they defined as cessation of the seizure within 5 minutes. They also looked at delayed control of seizures, so those seizures that stopped after 5 minutes but before 10 minutes, and then treatment failure, which was seizures that did not stop within 10 minutes. So in that enrollment period and with those inclusion and exclusion criteria, they were able to capture 52 seizure episodes and 26 patients got each intranasal midazolam and IV diazepam. And this study found that the drugs were equally effective at stopping the seizures within 5 minutes. Total treatment failures for each group, there were 3 in the midazolam group and 2 in the diazepam group, so no statistical significance there. And then the authors reported that the time from arrival to treatment with intranasal midazolam was almost 2 minutes faster. They were able to get the intranasal midazolam to the patients. And then the time from cessation of seizure after arrival was shorter with the midazolam. Time from seizure cessation after drug administration was shorter for IV diazepam. Other studies have shown that, IV benzodiazepines work more quickly than the other methods, but this study showed that the combination of the quicker time to administration and still the relatively quick onset of action led to overall quicker time to the seizure stopping with the intranasal medication.
So methodologically, a little more sound study, randomized controlled trial with a proper randomization scheme, and really seems to show at the very least that there's not a significant benefit to giving IV diazepam over intranasal midazolam. So intranasal midazolam looks pretty safe, pretty effective, certainly a reliable alternative.
Yeah, again, another study with better methods, but still not perfect. There's a lot of kids that were originally enrolled and they were excluded for unknown or unclear reasons. And, again, an unblinded study, which it may be impossible to really do a blinded study for something like this, given how quickly these interventions are given. But again, more direct evidence, but still sort of indirect evidence that the intranasal route is an acceptable alternative.
So even though this study, again, has its flaws with small sample size, poor description of the seizures that were included, and some problems with the way they reported their data, I like it because it introduces the concept even that giving a benzodiazepine by an alternate method instead of waiting to establish IV access can lead to shorter duration of seizure overall, which is important for all the reasons Indy mentioned with the last study, and then also the nature of seizures that last longer. They tend to be harder to control, and it sort of segues into the whole other body of literature that is out there that compares giving intranasal or intramuscular or any of these other routes of benzodiazepines preferentially first before attempting IV access. And I think, the big Rampart trial is an excellent example of a study that was well blinded and compared just giving something intramuscularly versus messing around with an IV in a seizing patient, and is one that is definitely worth looking at.
Okay, so tell me this. What has been the result of your looking into this topic and looking at this evidence?
My takeaway message from all of this was, even though, all of these studies are sort of small and flawed, it seems reasonable to conclude that intranasal midazolam is as effective as rectal diastat, which is what we tend to have to go to. And I do think, sort of anecdotally and in my experience, if you suck out the nose well, it is much easier to give intranasal midazolam. And I am much more inclined to ask for that in patients who come in without an IV, so we can get treatment started while we're trying to get an IV.
Agreed. I think this is going to lead a lot of us in our department to give this a shot. Momentum is sometimes hard to change. A historical medication that we know works fairly well, but it can't hurt to give this a try. There's no evidence from any of these studies that there's more adverse outcomes, more respiratory depression or the sort of things we worry about in these scenarios. What I'm actually really fascinated about this was whether this in the long term might lead to change in how kids with seizure disorders are managed at home. We send a lot of parents home with diastat, and they have a real tough time using this when their kid is actually seizing at home. So if there's a child that's seizing at home, that they have an easy access to a syringe and an atomizer to give this medication at home when their child is seizing, while they're calling 911 or whatever, that might be a real change for them and might make them more comfortable.
Yeah, I have two little kids, and I can tell you I'd much rather squirt something up their nose than try and get them turned over, rolled over, pants down,
Right.
stick something in the bottom, and hope that it gets in there properly.
Yeah, so the nose is the new thing.
It is. All right, well, this was another great topic, guys, and I want to thank both of you for being here and joining me and talking about this.
Thanks, Brian. Always fun.
Thanks.
And thanks to everybody out there for listening in. And don't forget to follow us on Twitter, where we are at EMJ Club. Check out our Facebook page. Check out our website, emjclub.com. And I hope to see you guys back next time.